Welcome, everybody. I'm really happy to see lots of friends here in the auditorium and new people. And thanks a lot that you're interested. I'm Volker. I'm an orthopedic trauma surgeon in Germany by training, and I do climbing medicine since, well, you'll see in the presentation, a long time. And I think I had most of those injuries by myself. I'm not looking forward to get all of them, but like I had my share. Um, I will be probably around 15 minutes, so we will have enough time to discuss. Let me just share my screen. Okay, so Jared, give me a thumbs up. Are we good? Okay. Short note on ultrasound and climbing injuries. So I'm not trying to give a lecture on all about climbing injuries or finger climbing injuries, but just trying to show a bit why we use the ultrasound, what we use the ultrasound for, and what we are going to present in our courses where we try to train on ultrasound. And by running courses in climbing medicine over probably now 30 years, I get to learn that the use of ultrasound or medical imaging over different countries varies a lot in the world. Like for me, as an orthopedic trauma surgeon in Germany, I have an ultrasound every time I see a patient in my room. So basically, nobody leaves my clinic without me doing an ultrasound and then deciding what else diagnostic means I would need. In other countries, you need to send the guys to an ultrasonographer, same for MRIs. So it is a bit difficult. So some of the recommendation also we give may be not working in your country because you just have a different system. Like we do a lot of MRIs because in my hospital we have 3 MRIs and it's literally 50 meters from my place where I run my clinic. So I can send them over, not at that day, but like in a few days. In other countries, the waiting time for an MRI is 8 months. So that doesn't really make sense. Okay, let's speak about ultrasound in climbing injuries and conflicts of interest. Well, I do have some conflicts as a climber. I'm with Adidas. I'm with 510. I do not have any conflicts with my medical talks, and I'm not sponsored for that. Speaking about climbing medicine, I'm one of the old people. You know, that's a funny thing. We ran this for a test like 3 times in the last 15 minutes, and now it doesn't work.
No, we can hear it. We can hear it.
So that is probably the time when I started not practicing medicine, but I learned about medicine. And some of the quotes I'm still using are from that series, and I feel like I'm that long in the business already. I'm not that long in the business, but I'm fairly long in the business. So I'm a climber since the mid 80s. That was during my high school time. I climbed a lot in Thailand in the early 90s here with Sam Lightman, my buddy. And while doing that, I was still in medical school, so I had no access to like diagnostic tools. But I early on, as a medical student, also studied acupuncture in Sri Lanka and in China, meaning I had a mean of therapy and treating climbing injuries already while I was still a medical student and didn't know everything else what to do with my friends when they got injured. So I basically tried to run a mobile climbing clinic early on. That was in the late 80s when we were traveling through Europe. And whenever one of my friends had an injury, I tried to like figure it out and get him some help because the knowledge about climbing injuries was very limited and also were diagnostics. We started diagnostics probably with the ultrasound in the 94, 5-ish or something. And that was mostly for abdominal. I was at general surgery at that time. And then we slowly started in the next 2 years doing exams on the fingers. And that were the images where we were working with. That was in the mid 90s where we tried to diagnose pulley injuries. And there was no guidelines, there was no nothing. I asked Thomas Hochholzer once, like when he told me to do an ultrasound of a pulley injury, and he was like on the phone, like, yeah, just do an ultrasound, see where the tendon goes. And so how is it like, how far away of the bone can it be? And he was like, well, maybe like 2 millimeters. So that was like the first benchmark, how we got to certain thresholds, which we later tried to prove scientifically was. But also just imagine that image is pretty blurry. And of course, that was one of the better ones because you always show the best ones talks. So that was how we looked into A2 pulley tears. So that was like a rough imaging, the 7.5 megahertz linear transducer in a water basin. And that's a tendon up here, and there's some fluid or whatever. So that were our means of diagnostic. And we came very far because that is what we do right now. This is a flexor tendon. This is an ultrasound. This is the A2 pulley here. You can see a little bit of fluid here, a little bit of fluid underneath in the recesses of the joint, but you can see clearly the pulley directly. We didn't do any of that in the beginning. We could just like look at it indirectly, like with looking at the distance to the bone, but not visualize the pulley at all. And that is my clinical machine, which works with 18 megahertz. And then Shaber works with 25 or 23 at least most of the time. So that's even much more better or more brilliant. And so the tools and the toys we got to our hands from the industry, they became much better. They also became much more expensive, obviously. And then nowadays we have the handhelds, which I can use for traveling with the team and looking at acute injuries, which help a lot. By teaching about climbing injuries, and we do an international climbing injury course in Germany in English every 2 years, and we did a couple of courses in the States, in Canada, with Canadian Climbing Medicine in Rio. And people actually address us all the time that they wanted to have a course specifically on ultrasound in climbing medicine. In Germany, we have ultrasound is just part of our training to become an orthopedic surgeon. It's mandatory, basically. And even for the exams, you need to talk about ultrasound and you analyze pictures and stuff. So that was basically the inauguration of the course we just did recently. And Jared put the whole thing up perfectly. So Shim and me, we just came there, gave our talks and everything else. Jared is perfectly organized it. And we had a great meeting with like, I think almost 40 people and a lot of experienced climbing physicians, doctors, physiotherapists. And the next one we are going to host in June, as Jared said, just before the Climbing World Cup in Prague, a really nice city. And I always love to travel there. For me, it's easy. It's only 3 hours driving, but it's absolutely worth going there. So speaking about ultrasound and climbing injuries, what is the classic injury? What's the injuries you mostly see? Well, most of the injuries I see over the years, and these are numbers for my outpatients clinic and inpatients in the hospital in the climbing area, and these are just the finger injuries because they are the most specific for climbing. It's not that necessarily the most frequent happening. Most frequent climbing injury is still probably the ankle sprain, but we just don't see them because they got treated everywhere. All the finger injuries, I get a lot of them for second or third opinion. And from the most frequent injuries, the finger injuries onto the pulleys, the tenosynovitis, the capsulitis, epiphyseal growth plate fracture, lumbical strain, joint capsule, they're all pretty much very well, with not the epiphyseal fracture, but all the others are very well detectable via ultrasound. So for the fingers, the ultrasound is the absolutely necessary tool, and I rarely do an MRI. Let's just dig into the pulley injuries firstly, because that's where we started using the ultrasound. You know, probably all of you know that we have 5 pulleys, and the important is the A2, the A4, and the A3, and these we can mostly neglect in climbers. We have that in trigger fingers, but it's not a super specific climbing injury. And there is a big variation of those pulleys, and there is like the C pulley, which are a joint enhancement of the joint capsula. And already Leonardo da Vinci showed pulleys in his ancient drawings. So for the diagnostics, and that's the old algorithm I started using, and that we brought up and came up with like, I think it was 2001 or something, and we used it before. So at that time we did not try to look at the existence of the pulley or see if it's halfway gone or something. We could just look at in the ultrasound of the dehiscence, like the distance of the flexor tendon to the bone, and if that's more than 2 millimeters or less, we say we have a strain, we have a single rupture, and if it's questionable, we'd go for an MRI. But honestly, nowadays I almost never do an MRI for that behalf. So we were looking for the dehiscence of the flexor tendon to the bone, and that, for all of you, that's the take-home message. That's super easy. But it's the clinical symptoms of a pulley injury. You may have these hematomas, actually, I rarely see them. Most of the time, you don't see anything from the outside. There's point tenderness at the level of the respective pulley, and then sometimes you have a bowstringing. And then we go for the clinical ultrasound. We're using the hockey stick. That's like the probe which goes up to 80 megahertz, and it's pretty small, and you can go longitudinal onto the bone, onto the finger, and directly see here, for example, the A2 pulley. What is very important is that it's a dynamic examination, and that's the advantage of the ultrasound versus the MRI. You can do dynamic MRIs, but that's pretty tricky. The MRI in general is a static picture of a status quo. But here with the ultrasound, first of all we allow them to move the finger so you can see the tendon gliding, and the way the tendon glides tells you that this pulley here is intact. If the pulley is gone, the tendon is not gliding, but it's leaving its bed. It's basically jumping up and down. And then you can also do a thing, it's called forced flexion, where you putting withhold onto the fingertip. Basically, you're keeping it down and telling the climber to put strength and stress onto it. And that actually gives even a more active pull of the pulley out from its bed. So that's the images of the normal pulleys we want to see. There is like a black area with a white line on top. That's the pulley, depending on the level of the angulation of the ultrasound probe. And it goes concave to the bone, and this is the line of the bone. And then for, that's the same thing. It's just the gliding of the pulley. You can see the lower margin of the pulley, of the flexor tendon and the bone here. So that is less than 2 millimeters distance, and you don't even need to do any static measurements. So what do we want to see in a pulley rupture? That's from our cadaver lab, where we did biomechanical testing on pulley ruptures, forms of pulley ruptures, eccentric versus concentric movement, and which pulley would rupture and which angulation and stuff like that. So these are like fresh frozen cadaver fingers, and this is a loading machine. And you can basically, the main thing you want to see for the A2 and the A4 is like, is the flexor tendon close to the bone or is it off the bone? That answers most of the questions already, even with not seeing the pulley directly. And then you can measure the distance of the flexor tendon to the bone. We take the mid portion of the base phalanx, and then you can statically and with forced flexion measure that distance. And you can see here that's probably 0.27 centimeters. So that's enhanced. That's an A4 pulley rupture because it's the distal phalanx. But also look at the gliding of the tendon. You can see it here that it's not gliding adherent to the bone. That was the A2. Now we're going to the level of the PIP joint. There's some effusion in the joint. And here the A4 pulley that is intact. So that would be the image of a pulley injury. For the A3 pulley, it's more tricky because you do not have a valid distance of the tendon to the bone, because that pulley comes not from the bone, but from the volar plate. So we need to look at the distance of the volar plate to the flexor tendon in forced flexion, and we have some cutoffs with like 0.9 millimeters, which has the highest sensitivity of a A3 pulley tear. Here you can even see the pulley directly up here, which is intact, and here it is missing. There's no pulley structure there, and you have an increased distance to the volar plate, and that's the dynamic examination. Here it goes in the other way around. That's the volar plate here. That's a flexor tendon, and the moment he's moving, you can see that the flexor tendon moves away from the volar plate, and you can see the increased distance. Other finger-specific injuries, it's the tendinitis, the inflammation of the flexor tendon sheet. That is also quite easy to be seen in the ultrasound because we are just looking at an increased level of fluid around the flexor tendon. Here in the short axis, we speak from a long axis if we go longitudinal to the finger like this, and we speak from a short axis if we cut across transverse planes. And you can see the inflammation here, the inflamed tissue with an increased ring of fluid called a halo around the flexor tendons as the sign of the tenosynovitis. And then you can use the Doppler, which actually records your blood flow, and you can see, which is a bit tricky, I need to accept, you can see an increased blood flow in that flexor tendon sheet. I do it all the time. I'm not like 100% convinced that it always shows an inflammation. Like if there's no increased blood flow, it doesn't say there's no inflammation or something. And then another topic where I use the ultrasound a lot is for the guidings of the injections. A lot of my therapy, I see patients mostly like once or twice. My clinic is like, first of all, it's surgical. It means like, is it a surgical candidate? Do we go for surgery or not? Then I would see him once and like twice post-op. Or if I'm on a conservative track, then I try to start the therapy, maybe do like one or twice an injection, sometimes 3 times. But a lot of those people who see me for this are not from my area, so they need to travel, and then they go off for treatment with a physiotherapist in their home area. So ultrasound guided injection techniques of the fingers and also the other joints are coming more and more into perspective and then getting more and more important. I was a bit reluctant at the beginning because I thought like if I can do anything good in medicine, I thought it's like injecting into joints and stuff because I do a lot of that. I don't think I'm a brilliant surgeon. I think I'm an average surgeon. Everybody can do that, but I thought I'm good in that. But if you look at the studies, they tell you totally different things. Like that study by Jones, they actually look, and that was 1993. So just remember the bad images we had in 1993. And they already improved the accuracy with ultrasound guided injections highly against blind injections. With blind injection, they only had an accuracy of 25 to 66%. And nowadays, with ultrasound guided injections, that can increase to 96% success rate. So significantly, the ultrasound improves the success rate of injection therapy. And you need to be aware of sterility. So we work consequently in a no-touch area. And then you have 2 general ideas where you can use the needle in correlation to your transducer. It's one is in plane. Then you will see a long image of the needle. And the other one is out of plane where you may only see the needle tip. It really depends on where you want to inject, which joint or which area, which plane actually works better. I use both of them, but it really depends on which joint you're injecting. Like the bursa, supracromial bursa, that's a lot where we do injections. There are different ways where you can get into the bursa. You can go from the front with a longitudinal plane. Here you can see really nicely the longitudinal image of the needle tip, and then you see the supraspinatus tendon, that's the bursa, and it's right in the bursa if you want to inject the bursa. I mostly do it from the back, like in these images, I use a longitudinal plane and inject, and here this just like the picture does not show the reality. There's a distance between the transducer and the needle because that's not happening. So in Germany, we have the rule basically you should have 1.5 centimeters distance of your needle and the transducer position. So I sterilize, I use no gel, I just use alcohol directly for as a transducer. I put the ultrasound probe there and get my image in the way where I want to have it. I re-sterilize, and then I get the nurse to give me the ready to go syringe with a needle, and then I go in. So I'm not moving anymore. So I'm a surgeon. I'm very scared about infection. So we really try to be clear here, not to do anything bad. Long biceps tendon, also an area where it's quite understandable that it's tricky to inject right into the right area because we do not want to be outside of the channel of the long biceps tendon in the biceps tendon groove, the anterior aspect of the humerus head. And certainly you don't want to be injecting into the tendon because that is just causing damage to the tendon and secondary tendon tears. So here also the studies show a very highly increased success rate with the ultrasound transducer in the injection techniques. And sorry, I skipped that picture, but mostly I use a transverse plane so I can see the tendon and the fluid around the tendon, and then like getting it from the side, and you can directly see the tip of your needle and then just make sure that the fluid runs very smoothly. There's no pressure, because if there's any pressure, you're in the tendon, just so you do not affect the tendon there as well. Most injections I actually do in the fingers is probably for tenosynovitis, tendonitis, meaning that the flexor tendon sheet is inflamed. Mostly the inflammation is where there is an angulation of the flexor tendon caused by the end of the pulleys. So wherever, especially if you're in a crimping position like here, the tendon gets a deflection at the end of the distal end of the A2 pulley, or at the proximal end of the A4 pulley. The A3 is so flexible, it doesn't really change the course of the tendon. So you can basically forget about that. So these are the spots of the tenosynovitis, and you can detect those with the ultrasound, and that's where you want to have your injection. You can see the ultrasound images here. This is the pulley, and this the inflammation just on top of the level of the pulley. And here you have a different finding. Here's this inflammation, and here's a peritenosynovitis. This means basically it's not in the tendon sheet, but this is just subcutaneous tissue where the inflammation basically goes to. So you want to have a different spot of injection there. For the tenosynovitis injection, it's a very small area where you need to have your linear transducer and your needle. So most of the time, I do not do these for sterility reasons, ultrasound guided. I do my ultrasound and directly see where the inflammation is and where I need to go. And then I still do the classical technique because I'm still thinking this is safer for me. I go into the flexor tendon sheet, then I poke with the needle into the tendon, and then you allow the patient to move the fingers, and the tip of of your needle is just in the flexor tendon, and it moves around, and then I slowly retract to a point where you can actually move the finger freely, and you feel a scratch at your tip of your needle, and that is basically when you are right there. And then I inject here, and secondary, I go through the flexor tendon onto the bone. And then there's always a space of like 1 millimeters below the flexor tendon. And by the opening of the needle just to the side, you can easily inject here. That's the safest injection technique to not harm the flexor tendon. I do a lot of those in tenosynovitis with cortisone. Steroid injections, I've never had any complications in those. Capsulitis, there I use the ultrasound regularly. Capsulitis, we just recently had a paper, whoever is interested on capsulitis, and Jared had one as well. So it's a chronic inflammation of the synovial sheet of the inner joint capsula, which you could call synovitis or capsulitis. Both terms are used. And treatment is, if it's not initially, and also don't get the understanding that I shoot cortisone in everything, I don't see the patient with the initial complaint. They don't come to see me because they have finger pain since 5 days, because like the waiting time is at least 2 months anyway. So the patients I see, they had all the conservative treatment already and still are having complaints. So they have a chronic condition. And then we go with injection with either steroids or with PRP, and sometimes with radiosynovectosis. This is a radioactive substance you can inject. But therefore, for all of these, you really want to make sure you're in the correct area into the joint. There are 2 ways basically to do that. There's the Spanish method, which Shaber and your friends are doing, basically going through the tendon into this palmar space. You see, this is the head of the base phalanx. This is the PIP joint. This is the palmar plate. But the joint capsule runs up to here. So this is all effusion. This is always there. And if you right in the middle, because on the left and the right side is the chicken ligaments, and there you can't inject. But if you're right in the middle, you get into that joint effusion filled joint space, and you can inject right there basically, and then the fluid dilutes into the joint. I do it differently, mostly because I've been doing it this way since 25 years. So originally we started with the fluoroscope to be sure that the needle is on the right spot, and nowadays I use the ultrasound. I'm just looking at the joint. I'm marking the level of the joint space in a long axis. So then I know exactly where the joint space is. I have the transducer has a little mark on the side that shows you where the middle is. And I try to get the mark onto the joint space. And then I do the injection like this. I still have my marker. I get into the area until I am at the bone. It's not always happening that you directly fall into the joint space because the joint space is so small. If you look at an X-ray, you think there's a space, but it's not a real space because there is the cartilage. So actually, that's why I then secondary in the next step take away the transducer and putting a torque onto the joint to open up an angulation so that the joint space actually opens up on one side. So I have a gap in between cartilage and cartilage. And that's where I then get into there with the needle. Great other course here on ultrasound injection technique, which is in San Sebastian. It's done through the friends from Scheber and mostly through Xavier. And it's an incredible learning possibility there. And yeah, so that was it anyway. Like I just want to show, like we have a couple of books out there, Climbing Medicine, One Move Too Many, and there's some part on ultrasound as well. And I'm gladly inviting you to come to Prague for our next course and hope to see you there.